very much, Dr. Nina. Before we proceed to our Q&A portion, we would like to introduce our reactor. Um, Dr. Ulf Feliciano also graduated with our class from the UP College of Medicine, class of 1990. He did his residency in internal medicine at St. Francis Hospital, Evanston, Illinois, and his fellowship in rheumatology at the University of Illinois in Chicago. Let's now call on Dr. Raul Feliciano, from the medical field.
So, good afternoon. Can you hear me?
Yeah.
Can you hear me? So good afternoon. So the talk today, we've seen that advances in molecular biology and understanding of the pathogenesis of inflammatory conditions, particularly inflammatory bowel diseases and inflammatory arthritis such as rheumatoid arthritis. So certainly a new generation of innovative therapeutic interventions have now replaced the old. And none of the old drugs can match the power and bioselectivity of these biologic agents. And in a way, they provided insight into the disease process itself. The last 10 years, we've seen an explosion and an expansion of biologic agents available for treatment of inflammatory bowel diseases and inflammatory arthritis. In fact, it started off with just two TNF-alpha inhibitors barely 15 years ago, and now there are more than 14 different biologic agents available in the market, and several more in the pipeline as we speak. They target key proteins and molecules in the inflammatory cascade. No? So they can actually be T cell, they can be B cell, or cytokine targeted therapies. So this gives the clinician a multitude of treatment options in the care of their patients. However, of course, with these options comes the challenge to maintain a level of expertise in prescribing and monitoring these drugs. The webinar today gave us a better understanding of the function and indications of biologic agents in use in inflammatory bowel diseases. So just as important, well, these new treatments are enthusiastically welcome. They're also a sort of inside concern and caution, which is just normal, given that there are new treatment modalities. So for my time today, my reaction today, I just want to touch base on three key issues. First is, are these agents really effective? And the answer is yes. Repeated studies have shown and consistently shown that biologic agents significantly reduce disease activity in inflammatory arthritis, especially rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. And certainly there are more results are way much better compared to old treatment modalities in the past, such as the usual disease-modifying agents. Another key endpoint that we always want to see when we look at studies is, do they halt or alter the progression of the illness? And certainly they do. Studies have shown that all biologic agents inhibit or retard radiographic patients with rheumatoid arthritis and psoriatic arthritis. The results aren't as robust in ankylosing spondylitis, though. And lastly, patients treated with biologic agents have increased functionality and are more likely to stay employed, and also have less cardiovascular mortality. So these all translate to a better quality of life. So we see here that the use of TNF-alpha inhibitors and biologic agents have indeed delivered on the outcome measures that we want to see. And certainly they have become key drugs in the management not only of inflammatory bowel diseases, but also inflammatory arthritis such as rheumatoid arthritis and the spondyloarthropathy. Secondly, I just want to discuss a little bit on two other biologic agents that were discussed previously and have been used more frequently and have gained their own reputation. One would be tocilizumab. Tocilizumab is an IL-6 receptor antagonist. We all know that IL-6 is a key enzyme in the pathogenesis of inflammatory synovitis and disruption on bone and cartilage. So This is a new biologic that's been available maybe the past 5 years, and it's been approved for the use in rheumatoid arthritis and juvenile rheumatoid arthritis. It has not shown to be effective in patients with spondyloarthropathies as opposed to TNF-alpha inhibitors. And the second biologic agent that I just want to mention would be rituximab. So it's a little bit different because what we had discussed before were cytokine-targeted therapies. They target specific cytokines such as TNF-alpha, IL-6, tocilizumab, and there's also other biologics that target IL-1. So TNF-alpha, IL-6, and IL-1 are the usual inflammatory cytokines that are targeted using biologic agents. What is unique with rituximab is it targets the B cell. So rituximab is important in diseases wherein B cells play a major role in its pathogenesis. So it's been approved in use in rheumatoid arthritis, vasculitis, and also in certain cancers like lymphoma, and also certain major organ involvement in lupus. It targets the CD20 molecules on the B cells. Just two quick notes regarding rituximab. They've been shown to have higher rates of hepatitis B reactivation as compared to TNF-alpha. So rates of as high as 5 to 10% of resolved hepatitis B reactivation with rituximab. So certainly a more vigilant screening on for patients with hepatitis B. And what has been mentioned about the anti-integrin and the risk of PML, rituximab has also shown a few case reports of increased risk of PML, as what Dr. Mina had discussed before. So again, caution in using these patients and these side effects. And lastly, I just want to touch base a bit about screening and monitoring of such patients. We couldn't emphasize enough the importance of screening for infections, as these agents certainly suppress the immune system. So active infections should be diligently screened for, as well as chronic ongoing infections. So in the presence of active infections or chronic ongoing infections, these agents are absolutely contraindicated. Dr. Amina had discussed at length screening and treatment of patients with TB and hepatitis B. Basically, I don't think I need to expound on that further. Regarding malignancy, TNF-alpha is important in inducing apoptosis in tumor cells. So there's been reports of increased risk of lymphoproliferative disorders and lymphomas in patients taking TNF-alpha inhibitors. And therefore, they are contraindicated in patients with a history of lymphoma or lymphomuscular disorders. Also, they've shown increased risk for melanomas, as well as non-melanoma skin cancer. So they're also contraindicated for patients with a history of melanoma or non-melanoma skin cancers. But they have not shown they did not show increased risk for solid tumors. So they're actually safe in patients with solid tumors, but although some experts would recommend that they be at least cancer-free for 5 years before they be started on TNF-alpha inhibitors. And also a little bit on demyelinating conditions. There's been some case reports of increased risk of demyelinating diseases such as multiple sclerosis, GBS, optic neuritis in patients with TNF-alpha. So in patients with such conditions, these agents are certainly contraindicated. And in fact, some experts would recommend in patients with a high risk or strong family history of demyelinating conditions to screen them for an MRI of the brain, and if you see silent lesions or occult lesions, then they probably wouldn't give in this subset of patients. Also these agents are contraindicated in patients with congestive heart failure class 3, class 4. So what do you do in this subset of patients? Maybe we can use other biologics that don't have increased risk for CHF, don't have increased risk for demyelinating conditions, a lower risk for malignancies, and these are would be your tocilizumab and your rituximab. So maybe that would be a better option in this subset of patients. So I think, and lastly, so the safe use of these drugs not only requires knowledge and experience, but it's also bolstered by guidelines and rules that we can follow. So certainly there's several scientific groups and subspecialty organizations that have come up with their own screening and monitoring of patients, and these are readily available. And we can easily get hold of these, and so that will guide you as to how to use these medications better. So drug safety must also be weighed against the severity and risk of the disease under treatment, but it is also just as important not to underestimate the impact of uncontrolled disease in decision making. I think that's, yeah. Thank you.
Okay, thank you, Raul, and thank you, Yvonne, for that exhaustive discussion on biologics with emphasis on inflammatory bowel disease. So we are now open for questions. Uh, we may be able to answer only a few questions as we have limited time. So first question, may I ask which biologics are available in the Philippines and are the cost of biologics for quantity and course? Dr. Mina?
What we have right now would be, I don't have the cost because having said that, we have infliximab and adalimumab here in the country right now. Raul,
Would you
how
have
about you?
yeah,
Rituximab, I think it's present.
Sorry, I didn't hear the question.
the cost?
Which is available right now. We do have infliximab and adalimumab here in the country, actually.
Yeah, there's
There is
infliximab.
there's going to be a tocilizumab study that's going to be launched this for IBD. So
There's also etanercept. It's a TNF-alpha inhibitor, but it's a soluble. It's a difference. It's not a monoclonal antibody. So unfortunately, Dr. Amina had not mentioned that because it's not recommended for inflammatory bowel diseases. It's not as effective as infliximab. I think Dr. Amina would agree that etanercept is, I think, not approved, right, for inflammatory bowel diseases. Yeah, it's not yet, but it's also a TNF-alpha inhibitor. Uh, yeah, other biologics like rituximab, IL-6. But if you're just TNF, yeah, I think those are the only three that are available. There is ustekinumab actually, which is for psoriatic arthritis. That is against IL-12 and IL-23. That's also available here in the market, here in the Philippines.
there are ongoing studies actually for using ustekinumab for possibly for IBD, but still not released for that indication.
Yeah, because ustekinumab is only approved for psoriatic arthritis. It's not yet approved for rheumatoid arthritis and the other inflammatory arthritis.
Okay. For rheumatoid arthritis, may I ask Dr. Feliciano, what is the cost of a treatment course in biologics, let's say infliximab or other biologics? How much will it cost to have a treatment course?
They can range depending on the obviously depending on the biologic agent. They can cost anywhere from 30,000 to 60,000 a month. So a bit quite expensive. Yeah.
I hear that they are covered by the corporation. But in the Philippines, is there a chance that the PhilHealth will soon cover for biologics?
I'm not from.
I don't know, but even in the United States, I mean, there is always a question of insurance covering biologics for these patients. So I don't think it's going to be happening here, happening soon.
But it is indeed covered in the U.S. So that's why you'd be very fortunate if you're an American citizen. These are covered by HMOs, by insurance companies in the U.S. There just has these certain strict guidelines that needs to be followed when prescribing this medication. It's just not, you just can't prescribe them just like that. You need to sort of a set of criteria before you can. This will be covered.
Okay. This may be the last question to be answered by both speaker and reactor. What is the worst complication that you have encountered in a patient that you have given biologics, and have you handled it? First,
Worst,
Dr. Mina.
um, nothing that was, well, TB. There was a reactivation of TB. She was actually treated for TB in the past. So she had gone through the recommendations of screening and all that, but she still developed TB. But she got better with stopping of the biologic and anti-TB treatment. And infections. Nothing really serious, but a few patients have had that, some infections like pneumonia, UTIs, but nothing very severe.
Dr. Mina, would you
I
have
would
any
still I
experience?
would still say infection would still be the I mean the more common adverse drug reaction that we see. Having said that, actually the most common problem I have actually with patients who I've started sometimes on the on the agent is for them to maintain because it's costly. So some of these patients might not be able to do maintenance therapy. Okay, in connection to that, I guess one of the questions that always come up during is will the will they be able to stop? Because if you note, we do episode, I mean, we do the induction therapy, then afterwards place them on maintenance therapy. Okay, of course, there's some reports that for rheumatoid arthritis and sometimes for IBD who have already achieved mucosal healing that you might stop, no? But we do know that they can relapse. If they relapse, yeah, then we might give them another dose again. We start again the anti-TNFs. I guess the question because we learn actually more from Ruma. Um, how about who are the patients you've stopped biologics on, or you maintain them forever?
You, the recommendations maintain them forever because these are not cure. These
Yeah, the
medications
relapse rate.
they're not cures. No? So you're just basically controlling the disease. So eventually, once you stop them, the disease will come back. But the thing that I've noticed is the disease does not come back right away. As opposed to, let's say, methotrexate or other oral disease-modifying agents. When you stop them, they usually get a relapse weeks or months or even weeks, as short as several weeks. What I notice about biologics is, especially when they've been on it for a long time, that when you stop it, they don't relapse right away. So, you know, that's still a plus because certainly because of the expense, you want them to be disease-free for the longest amount of time, right? Because it's no expensive medication. So yes, we don't normally, it's not recommended to stop. But if you do stop them, then there should still be oral disease-modifying agents on board. Like you don't stop your methotrexate, you don't stop your sulfasalazine or anything that they're on when they were on the biologic agent. By the way, you can actually, for some biologics, the use of disease-modifying agents is recommended. Especially, for example, like infliximab, like Dr. Min had said, because of formation of anti-chimeric antibodies. So disease-modifying agents actually prevent formation of antibodies. These are true for biologics that are chimeric, part mouse, but fully humanized, such as adalimumab. You don't normally see production of antibodies.
Okay. Thank you for that engaging
Yeah.
discussion. And if you have more questions, you can email us at webinars1@gmail.com. Unfortunately, that's all the time we have for this webinar. So we'd like to thank our speaker, Reactor, um, and our sponsor, Johnson & Johnson. After the session, we will be sending a survey link to the participants. Please answer the survey so we can assess our webinar. We will invite you to our next webinar on January 6, 2016 on there's also Wednesday, 12 noon to 1 p.m. and 1 to 2 p.m. The topic would be asthma from 12 to 1, area from 1 to 2. And our speaker for both is a pediatric allergologist from St. Luke's Medical Center. May we also invite everyone to our CMA conference on December 15th at the hall at the UP College of Medicine. You can also live stream at livestream.upm.edu. So in behalf of the UPCM Class 1990 and the UP Medical Alumni Society, we would like to thank our sponsors and all our collaborating units, the Health Center, ISF, Medicine, Medical Informatics, USP, SP, and Ms. Curtis Farhat, our host. This is Dr. Henrina, together with Dr. Mina and Dr. Lino, and the UP Medical closing this session. We hope you have learned a lot from today's webinar.